Thanks, Cindy. Welcome, everybody. Just like Cindy said, I'm the orthopedic service line manager here at St. Joseph. I am going to talk about Makoplasty, but I've divided this talk into two parts so it will help you understand, because we can use Mako for hip and knee. So I'm going to talk first about knee and then follow with the hip. So briefly looking into knee, types of knee pain. There are two types of knee pain: acute pain, chronic pain. Acute pain probably due to the injury. Chronic could be different reasons, but mainly due to osteoarthritis. So then we talk about osteoarthritis. What is osteoarthritis? Really, osteoarthritis is when the cartilage is breaking down. That's what it is. 15 million Americans suffer from osteoarthritis of the knee. And sad to say, but 46% of people will develop knee osteoarthritis over their lifetime. So I'm sure in this room, few of us will. Causes of osteoarthritis. You will often hear people saying, or doctors saying, bone on bone. That's really the other term for osteoarthritis. So bone on bone or osteoarthritis could be due to long-term impact on this knee, which could be related to work or could be related to sports, genetics, and obesity. Well, there are other causes unknown as well, but these are the reasons we know of. This is just showing the x-ray on what the normal knee is looking like versus the arthritic knee. Treatment. How are we going to treat arthritis? Well, number one, we tell patients weight loss if it is applicable. Sometimes it's just not. They're already skinny and they're having knee pain. And then from weight loss we start with medications, NSAIDs. So the NSAIDs could be in an oral form or it could be injectable. Oral form like Celebrex, Motrin, Advil, and Aleve. And NSAID, for the joints, we can also give steroid shots if it's due to swelling, and sometimes if they see it's more like it's another shot is called Synvisc. So one or the other, depending on what is needed. Changes in activity. Pretty much we tell patients whatever, when you try to do something, it's hurting you, don't do it. Try to modify it. That's just pretty much the course. And that's what it gets really sad. You tell patients, okay, don't do it, but what if it's walking is hurting? Well, we got to take care of it. We just can't let patients sit around, and when things are not working, the course of treatment is not working, that's when the last resort becomes surgery. Just briefly, symptoms could be pain, swelling, stiffness, decreased range of motion, instability, and reduced activity like we said. And sometimes patients are okay with that, so often we will say, you tell us when you're ready for it and come back. If they're okay with that reduced activity, they're okay with that lifestyle, then that is okay for them. But if that's not how they want to live, then we start talking about how are we going to take care of this. So when we talk about knees, because all the other modalities I talked about, now they didn't work. We got to do something different. So first, we can actually plain simple just do arthroscopy. We call it a clean it up. Just same day procedure. Patients go. We can just remove or repair the damaged structure. That's all we're gonna do. Partial knee, the traditional way. Partial knee has 3 compartments. If 1 or 2 compartments are only damaged because of whatever reason, then we're just gonna repair that. But if all 3 parts are damaged, then we call it a total knee. So when we're going to do partial is easy because of course you're only tackling half of the knee. The somewhat of their knee is left, so there's more flexibility. But the challenge comes with partial knee is alignment. You got to make sure it is aligned because you're not doing the whole entire knee. You only did 1 part or 2 parts. So that is definitely the big challenge there. Total knee, like I said, we're going to replace do the entire knee. That is all 3 compartments. It's considered gold standard for the osteoarthritis. But you all know that. But you're here to hear what is Mako going to do for me, right? So let's talk about it. This is a little bit just the limitations. We can come back to it. So this is the robot we all talking about. Some of us call it robot. Some of us call it Mako. Really what it is the Mako robotic arm interactive orthopedic system. So how does it work? How it works is once it's decided the patient is we're gonna use Mako for the patient, the surgeon will send that patient to have a CT. Now with the CT, we get the patient's knee image. We all know we're all sitting in this room, we're different make, everybody is different size, differently aligned, so we have to make sure whatever the alignment was, we gotta put it the same way. So now they have the CT guided, all the numbers, all the data from this patient is fed into the system. And as you see that, the very third surgeon controlled robotic arm, he is gonna be using that on whatever the data was fed in the computer. Now when this data is fed, surgeon and the rep are there, they make sure that this is done, because last minute he could make changes on what he wants to do. This is live thing happening, because a lot of the other robot, surgeons really not doing it, they're in a different area. This one, they have the arm and they are actually working with it. So the benefit of that, what happens is when the data they have fed in, the arm would not let them go outside the area you want them to, because what that happens, but manually when you're doing it, that is a possibility. That one thing is that won't let you go outside the area, and not only that, won't let you burr the bone deeper. And that is where we see, because it's not outside, nothing more is damaged, nothing more is kind of touched with that, and because the burring happened to the exact degree what we wanted, that is why we see the benefit of this. I'll get into the benefit, but before I get into the benefit, briefly, Makoplasty, once again, we can do it the medial, patellofemoral, lateral, or medial and patellofemoral. So these are all partial, but as of right now, Mako can only do partial knees. Is it not for total knees? So it's just partial knees. Total, we're hearing we will have it by 2014 January, but not yet, okay? So what are, this is just the knee x-ray images. What are the benefit? Faster recovery, smaller incisions, less bone resection, limited pain, minimal blood loss, hospital stay 1 to 2 days. And we can say that because going back to the reason what the benefit was because we are not doing anything to the undamaged area, and because we're not digging but burring the bone deeper, that is why we have that benefit using this robot. So any question before I go into? Okay, so until now, from since 2006, with Mako, we have performed, not we, but the Mako, we not in this hospital, over 20,000 procedures have been performed, and this slide really shows you the difference between Mako and the total traditional knee and total knee with computer assisted, because there's also such thing where you can also do knees with the computer assisted, which is not as lively, because once you fed the number, they just stay there and it doesn't do anything helping with the arm when a surgeon is doing it. So yes, it's better than the traditional knee, but not as good as the robotic arm. So it just kind of tells you have a significant increase in number of step, post-op range of motion, quad strength, which in result has given us greater post-op mobility. So before we go into hip, is there any question on knee I can take? All right. So briefly, because pretty much same, arthritis is another cause of this, so I'm not really going to go bore you with another arthritic issues, but just giving you the anatomy part. This is just the hip anatomy and degenerative joint, just like how it looks. A little bit different reason why we would have this is it could be due to post-traumatic injury, rheumatoid arthritis, avascular necrosis, hip dysplasia, and again, osteoarthritis, again, is one of the biggest cause of hip replacement surgery. Symptoms, pain, but pain when you put weight on that leg, which is you're having the issue with. Limping to decrease pressure on the affected hip. Pain radiating to groin or back, and this is one of the reasons often our hip patients go to the spine surgeon first, because this pain is radiating from the back, and they're thinking, oh, it's my back. When they start doing the workup and find out it's not really your back, it's actually the hip. Hip pain or stiffness during walking or other impact activities, And of course, failure to respond to non-surgical treatments on non-steroidal, when that happens, that is when we're going to go to the last resort, which is going to be a hip surgery. So before, just briefly, treatment, IT band stretching, and I have some exercise I'll show you on the next slide. What are the IT band stretching? There are really the gold standard. Once patients start having hip pain, our doctors tell them that is, start doing those stretches, and that seems to really help. Local modalities, once again, doing patients just the local area, target just that hip area, NSAIDs, rest. Once again, if it's bothering you, rest. Don't walk on it. Cortisone injections, and the last resort, surgery. So this is just the IT band stretching. These are, you Google it, they're all over, but that's just pretty much just the main exercises, stretches we tell our patients. You all know what the traditional hip surgery is. Once again, let's talk about hip surgery with Mako. Well, hip surgery with Mako is, like I said, with the knee was only partial, but this is a complete hip surgery done by Mako. So the easiest way for me to explain is that with traditional versus Mako would be, after you look at this picture, is alignment is the key. You can have a really expensive good car, but if the wheels are not aligned, it's not going to do the right job. It's not going to work as good. And that is really the key with Makoplasty. Now it's a little bit differently the way, again, they are going to do the CT guide just before the surgery, just like we did it for knee. And then when the data is fed in the computer, when surgeon is ready to do it, in this one, alignment is the key, the leg length is the key, which is a really one of the number one reason for suit file for hip surgery is indiscrepancy in the length, and that is really a big deal for us with this surgery. So one by one, reduce risk of leg length, like I said, risk of dislocation, improve soft tissue tension, improve post-op range of motion, improved implant survivorship, and rapid pain relief and return to daily activities. This is just like the way it's showing, and that is really the arm when they're doing it. They have actually pressure points, which that's the pressure point is what guides them. That is the implant how is implant being put in and all that. It takes a lot of prep time, and that's one of the reasons sometimes surgeons don't like to use it. There's a lot of prep time before the surgery. Before we actually had a Mako here, I flew into Portland to see, and the very first surgery I'm all in the case, and I'm thinking, when is the surgery going to start? It takes literally 15 minutes to feed the data, making sure everything is right, but once they get started, it's really fast. But that is really the key, and that's one of the reasons why some surgeons are like, they just think, I'm good. Why do I need to play around with this machine? So am I a candidate? Just the typical process is going to start with the office visit. Of course, the physical exam, x-ray is going to be taken. Once it's identified that this patient is going to have Mako hip or Mako knee, that's when we will send the patient for CT scan. Because if we're not going to do a Mako hip or knee, CT is really not needed. They will have a pre-op education class at the hospital, of course, admission testing. Procedure time is still 90 minutes, and length of stay is anywhere from 2 to 3 days. Once they go home, they will have a physical therapy at home, unless they decide to go to actually, rehab, but more and more patients are going now home. So usually they will have 3 weeks of home therapy followed by 3 weeks of outpatient therapy and in-office follow exam, of course. So final thoughts, really, hip and knee problems are fairly common. Stay within your limits. Back to, I would say, if something bothering you, stop doing it, let that heal, and then go forward. Listen to your body. It's very important. Work harder, but smarter, and know when to seek help.